Good morning, dear students. Our next lecture is dedicated to newborn jaundice syndrome. I'm a lecturer, PhD, Karzava, assistant of Department of First Pediatrics and Neonatology. So, hyperbilirubinemia, it is neonatal jaundice. We will try to understand the causes of hyperbilirubinemia today. Neonatal jaundice is a term used when a newborn has an excessive amount of bilirubin in the blood characterized by the jaundice. Jaundice is a visible manifestation of increased level of bilirubin of the body. The yellowish pigmentation of skin, conjunctival membranes, and sclera. Jaundice, it's not disease. It's rather a symptom of some pathologic disease, pathologic conditions. Bilirubin is a product of the hemoglobin breakdown. Hemoglobin is conjugated in the red blood cells. Normal TCB level is newborn would be under 5 mg per deciliter. So TCB level is usually rises term infants to peak level 12 mg per deciliter by 3 days of age. In preterm infants, peak level occurs in the 5th days of age. TCB can rise over 15 mg per deciliter. Bilirubin can cross BB lead to the permanent damage irreversible, which is why high CBR is so dangerous. Normal bilirubin metabolism. Red blood cells will damage and we will organize hem and globulin protein. It is amino acid protein. Hem will oxygenase way will convert to bilirubin. Biliverdin will the exchange to bilirubin reductase and conjugated bilirubin, and it will bond in intestinal with albumins and uptake with liver cells. An unbound type is very easily cross through the hematoencephalitic barrier. It is because lipid soluble and will damage the brain or will occur toxic effect to the brain. Objective: predisposing cause of neonatal jaundice. We have pathologic and physiologic jaundice, neonatal jaundice. Let's discuss physiologic jaundice first of all. Due to the elevation of unconjugated bilirubin concentration, occurs in the first few days after birth, cleared by day 10. It's a consequences of two factors. First is related to the immature of liver enzymes. Second, it's related to the when fetus breathes the oxygen. So his sclera skin will color with yellowish discoloration. Physiologic jaundice mechanism: newborn baby has a hemoglobin level 18-19 grams per deciliter, necessary during fetal life to facilitate oxygen carrying capacity. When the baby born and able to breathe oxygen, high hemoglobin level is not needed, then starts to drop. What is the mechanism of the dropping hemoglobin? So, in the first week of the life, baby's hemoglobin will be dropped to about 11 grams per deciliter. Breakdown of the fetal red blood cells cause bilirubin to exceed to the plasma. It is physiologic jaundice. So, glucuronidase transferase enzyme GTP enzyme present in liver and normally converts unconjugated bilirubin to conjugated bilirubin. Before birth, if we will see before birth and after birth, before birth, the enzyme is activity down-regulated because bilirubin needs to remain unconjugated in the fetus in order to cross the placenta to avoid being accumulated in the fetus. Yes. Second, after birth, if we will see after birth, it takes some time for this enzyme to gain function. This is the time the fetus will increase unconjugated bilirubin to the in circulation. It will lead to jaundice, naturally. Pathological jaundice, it's a sign efficient in the first 24 hours of life. It may persist more than 2 weeks, refers to jaundice that arises from factors that after the usual procedures in bilirubin metabolism in the liver, hemolytic, non-hemolytic, we will have hemolytic types, intrasthenic and extrasthenic types. Hemolytic causes, membrane condition of red blood cells, spherocytosis we have, intrasthenic, it is causes, enzyme condition, GDP deficiency, globulin synthase defect, sickle cell disease or thalassemia, it's disease of shape of erythrocytes. And extrasthenic reasons, rhesus factor hemolytic incompatibility, ABO system incompatibility. So, hemolytic causes, intrasthenic causes. Let's discuss spherocytosis. It is hereditary familial disease. Morphologic hallmark is a macrospherocyte of red blood cells, sphere-shaped rather be concave-shaped erythrocytes that cannot give oxygen, cannot take oxygen on his surface, and it will go very fastly break down. So let's discuss next types. Next type, it is in the enzyme conduction, GDP deficiency. Hereditary, it's also abnormality in the activity of an erythrocytes. The enzyme is essential for assuring a normal lifespan for red blood cells. Hemolytic causes, extrasthenic causes. So, RH incompatibility may occur if mother is RH negative and fetus is RH positive, will born with positive RH. ABO incompatibility. ABO may occur if mother blood group is O and fetus blood group is as a or B. This is extrasthenic causes. Non-hemolytic causes we have also breastfeeding failure, breast milk jaundice, and polycythemia. Breastfeeding failure caused by insufficiency of milk intake because of difficulty in feeding, or if mother doesn't have an adequate milk supply, some somatic or some severe conditions of mother after delivery. So leading to the dehydration or low caloric intake of baby. So baby will get yellowish day by day. His condition will be worse. But it's connected with the amount of milk, yes? Next, breast milk jaundice. Mother breast milk may contain some of mothers inhibitor of bilirubin conjugated, some of mothers. interruption of breastfeeding for 1-2 days, it is enough. It will give results in a rapid decline in bilirubin level. If 1-2 days we will stop breastfeeding after interruption, if bilirubin level will be declined, we may put diagnose breast milk jaundice. Next, polycythemia, an excessively high hematocrit, it is 65%. Gilbert syndrome, septic conditions, or Crigler-Najjar syndrome. Gilbert syndrome is caused by mutation of promoter of region of glucosidase transferase enzyme, hepatic enzyme dysfunction due to this, and lead to mild hyperbilirubinemia. Gilbert syndrome, it's not serious. It will appear on individuals even in teenager period or in adolescence period even. Next, Crigler-Najjar syndrome is a lead to carinectors, very serious type of bilirubin encephalopathy, deposition of indirect bilirubin in brain cells, especially in basal ganglion, jaundice, lethargy, poor feeding, high-pitched cry, hypotonia, and seizures will be visible by clinical symptoms. So we should differentiate physiologic jaundice with pathologic jaundice. Physiologic jaundice, if it's appear after 24 hours, second or third day, pathologic within 24 hours will appear. So level of bilirubin, maximum intensity between third, fourth of days, it is physiologic jaundice. Pathologic serum bilirubin rising at rate 0.5 mg per deciliter per 24 hours. Serum bilirubin more than 12 mg per deciliter, and pathological, in case of pathological jaundice, serum bilirubin less than 13 mg per deciliter. So by duration 8-14 days in case of physiologic jaundice. In case of pathologic jaundice, persists after 14 days of life. So physiologic jaundice, no treatment required. And pathologic, we should try to treat. So causes of neonatal jaundice by age. Which causes by age? Causes more than 24 hours of life, 72 hours, after 72 hours. This table shows some differences due to ages of our baby, neonatal jaundice by age. It's GDP deficiency, polycythemia, for example, breastfeeding jaundice. We should provide differential diagnosis, and we may put diagnose. So, if jaundice is prolonged more than 1 week, we should think about pathological jaundice, breast milk or Gilbert, Crigler-Najjar, or biliary tract some obstructive conditions. We could suspect the diagnosis by the time, but we couldn't confirm it. We have to do additional investigation to the baby, take postnatal and prenatal history, familial history, and if we should know also duration of, in case of prolonged hyperbilirubinemia. So, what's postnatal history? In which day of jaundice is present and for how long time? Because it will be pathological if it starts from first day within 24 hours of life, and it starts from second and third day, but it continue more than 1-2 weeks. Feeding breast milk or formula, because the type of feeding, type of jaundice related to the problem in the breast milk itself. So, how adequate your breastfeeding for your baby, because the type of the jaundice occur when baby is not nursed well or mother's milk is slow to come in. Is jaundice related after interruption of breastfeeding or about 2 days? Because there is a relieving of jaundice is indicate breast milk jaundice. The current weight of compared to the birth weight to know the progress of growth or regress of growth. So, urine and stool production. What is the color of stool urine? Infectious or fever, associated symptoms, lethargic, poor hypotonia, poor feeding will be helpful to put diagnose. Next, familial history. We should pay attention for previous sibling with jaundice in the neonatal period. Brothers or sisters of this baby maybe they will have some hemolytic causes or some familial, some erythrocyte pathology. Presence of anemia, liver disease, or bile stones, yes, familial membranes or members, or known hereditary of hemolytic disorders. So, because all of these previous conditions can lead to the accumulation of bilirubin in circulation blood. Prenatal history, maternal infections, maternal illnesses, maternal blood group, maternal medicine or drug intaking, delayed cord clamping, and etc. Conditions we should to clarify on mother's history taking. In summary, we may say that jaundice within 24 hours is always pathologic. Lethargy in poor feeding, hypotonia may indicate chitinectosis. A detailed history is an essential part to the research probable diagnosis. For today, it's only we discussed the differences of hemolytic and physiologic and conjugated, unconjugated hyperbilirubinemia. In next classes, we will stop each types of jaundice in detail. So thank you for your attention, guys.